All right, good morning, everyone. My name is Beau Hennemann. I'm Director of Special Programs for Anthem Blue Cross, and welcome to today's panel at the State of Reform Conference, which is entitled ECM, HCBS, and ILOS, the Vision of CalAIM's Power Acronyms. Just a couple of things before we get started. If you're looking at your agenda, you're probably expecting to see a couple of other people here. I know Bruno was going to moderate today's panel, and at the last minute got pulled into something else. So I'm gonna do my best to take on that role for her. I will say I'm not near as smart or as funny as Kelly, but she left me some pretty good notes, so I'll try to do justice to the role. We're also still waiting for one of our other panelists, Martha Santana Chin, to join us from HealthNet. So hopefully she's able to get on here relatively quickly. So I'm gonna go through this, and I'll let Susan introduce herself, and we're really gonna keep this pretty open in terms of doing a pretty general Q&A type of format. I have a couple of questions for each of the panelists, including myself, that we'll run through and then open it up to Q&A kind of for the second half. Just a couple of quick housekeeping things before I get into the introduction. One is when we do get to the Q&A session, or really throughout any of the presentations, the way to pose a question to us is really through the Q&A section here in the web platform. So if you type your questions in there, that's where we'll be picking them up and we'll monitor them as we go along, but again, spend quite a bit of time at the end going through Q&A as well. Other things, I think everybody's already muted is my understanding, so that takes care of, one of the biggest issues we have with these web-based platforms is people going off mute, so hopefully that's taken care of. And, logistically speaking, the only other thing I can think of is restrooms. If you need to get up and use the restroom, please do so. Go through this door into the main house. Second door on the right is where the restroom is. Hopefully you've got one that's actually a little bit closer, though, and you're not showing up at my house and trying to do that, but just in case. So with that, I'll jump in. And, this session, is really focused on CalAIM, which hopefully is not a new topic to anybody that's participating at this point. It is something that we've been in discussions on for really a couple of years now, and something that we're working really hard to get implemented and up and running by January 1st of next year. So hopefully it's not new. I did notice that on the agenda, I think this is the only session today that actually has CalAIM in the title. But I'd be willing to bet that you're going to hear the topic of CalAIM come in and out of several of the other sessions as well. Looking through the agenda, there's a lot of different topics today that in one way or another are either impacted by CalAIM or touch on CalAIM in some way, shape, or form. So, with that, just some open remarks about this this session and this panel. This is titled, oh good, Martha, you made it. All right. So this session and panel, is titled on focusing on the acronyms and how we're leading into CalAIM. I think we're really not going to stick too close to that and focus on those three acronyms that are listed. We're going to dive deeper into some other components of CalAIM. The reality is three acronyms isn't enough. We live in a world of acronyms, and there's probably about 100 acronyms that are wrapped up in CalAIM. I think the ones listed here in the title are some of the more core, the more critical ones. However, I will say that, things are moving at a fast pace. And Susan, I don't know if you're planning to touch on this or not, but one of those acronyms may actually be changing and disappearing from the title very soon. I'll let you guys guess which one, and then Susan, maybe you can call it out. So, that's going to be the focus on our discussion today. We do have, kind of like I said, a round of questions that I'll pose to the panelists, and then we'll open it up for general Q&A. I do want to do a couple of quick introductions. Let Susan and Martha introduce themselves. Again, my name is Beau Hennemann. I'm Director of Special Programs for Anthem's California Medi-Cal team, and really leading up our efforts statewide to implement CalAIM. So I'll kick it to Martha first, I think, to introduce yourself. And if you're confused as to why I'm talking, Martha, Kelly had to bow out at the last minute, so I had to take over as the moderator as well.
Well, Beau, we're in good hands with you at the mic. Very agile here, and we're all kind of playing. And first of all, I apologize for being just a couple minutes late. I myself had some technical difficulties, and I've learned a little bit something new about this platform. So happy that I've learned a new trick here. But I'm Martha Santana Chin. I'm Medi-Cal President for HealthNet of California and California Health and Wellness. And I have the pleasure of working alongside Susan and Beau in the implementation of CalAIM, along with an extensive number of individuals on our collective teams, and very much look forward to the conversation today.
All right. Thank you, Martha. And Susan, you want to introduce yourself?
Sure. Hi, everyone. I'm Susan Phillip, Deputy Director for Healthcare Delivery Systems at the Department of Healthcare Services. And my division of Healthcare Delivery Systems oversees the managed care divisions, including operations and policy and development. And I joined DHCS in late April. And I'm thrilled to be joining DHCS, especially at a time when we're really trying to advance many of these goals, as we're going to hear more about today. And also thrilled to be working with our plan partners and be on this panel. So looking forward to the conversation.
All right. Thank you very much, Susan and Martha. So to start things off, we did want to set the stage just a little bit. And, as I mentioned at the beginning, hopefully this isn't the first time all of you have heard about CalAIM, but we don't want to assume that you're as deep into it as the three of us are, which is really, 25 hours a day, 7 days a week at this point, working through CalAIM implementation. It's become pretty intense. So we did want to start with some level setting. And so Susan, I'm hoping you can help us by giving kind of a high level overview of what CalAIM is, what some of the policy implications are, and really kind of set the stage for the rest of our conversation today. And I believe, Patrick, yep, there we go.
Great. Yeah, I will be happy to tee this up. We do have a few slides, and I am going to be chatting for a little bit. So that would be helpful for us to, kind of give the big picture and set the stage, and then get into a little bit of level setting on what these power acronyms are, and then we can get into the conversation. So from a big picture perspective, CalAIM stands for California Advancing and Innovating Medi-Cal. And the whole purpose of CalAIM is to transform Medi-Cal and really create a new and better Medicaid system for our beneficiaries, really to help better coordinate care and expand services that are easy to access, and really design the program to improve people's health and life trajectory. Ultimately, everyone has a stake in a better Medi-Cal program, and we all know someone who depends on Medi-Cal, right? About 1 in 3 people in the state are covered by Medi-Cal. 51% of all births in California are covered by Medi-Cal. More than 55% of all patient days in long-term care facilities in our state are covered by Medi-Cal. And CalAIM is really our long-term commitment that it's going to take some time, again, a long-term commitment to fully implement and achieve California's commitment to, a healthier society. So if we get to the next slide. The next couple of slides, I'm, going to walk through our primary goals. I'm sure that we could go to the next slide, actually. All right, yeah. So the 3 primary goals, I think you will have seen this also. This is the main thing that you'll see when you go to the CalAIM landing page. But I do think it's worthwhile for us to level set on the goals. It really is to identify and manage member risk, really build on whole person care approaches, and address social determinants of health. We really are trying to also move Medi-Cal to be more simple, less complex, try to reduce some of that complexity, and really try to make it more consistent and seamless for our members, and as well as our providers. And then, of course, we want to keep our eye always towards quality and really driving delivery system transformations through value-based initiatives and modernizing our systems. So, today Medi-Cal really has challenges in meeting the needs of our diverse population. And, so we're really trying to approach this from a population health standpoint. And we know that, certain populations have greater needs than others. So we're trying to take a targeted approach. So we can move to slide 4. So I want to get into a little bit on what is ECM, or Enhanced Care Management, and community supports. And so I will say this is the acronym that is going to be replaced, ILOS, which you have heard of before, which it was in lieu of services, which is an acronym that basically says what it's not. It's not a very helpful acronym. So we really wanted to move to a term that members could understand, that is more intuitive. So community supports really captures the notion of home and community-based services, and really providing a set of services that wrap around and provide additional services beyond the traditional medical set of benefits. So, so you'll now hear us using the term community supports instead of IOLS, or in lieu of services. So we, as a department, we're really trying to be more intentional about the use of these terms. So if we can move to slide 5, I'll just define what ECM is. So Enhanced Care Management is a comprehensive set of services and attempts to address the clinical and non-clinical needs of high needs, high cost Medi-Cal members through systematic coordination of services and comprehensive care management. The idea is that, it will be interdisciplinary, high touch, person-centered, and primarily provided through in-person interaction with members, depending on where they live, where they seek care, and where they prefer to access care. ECM is intended to be available to all high needs Medi-Cal members who meet the Enhanced Care Management Population of Focus criteria. So community supports, if we can move to that slide there. You know what? I think we need to go to the previous slide here. Can you go back there? And then go back one more. Sorry, went a little too fast. There you go. Yes, we can stay here. So community supports are medically appropriate and cost-effective alternatives to services covered under Medi-Cal. And this is optional for our plan partners. Plan partners are encouraged to offer, a really robust menu of community supports to address conditions that, are caused or exacerbated by social determinants of health. So for example, food insecurity or unstable housing, or again, other social determinants of health concerns. Again, community supports are optional for plan partners to offer and for the member to use. Okay, now we can go to the next slide. Okay, so so in addition to improving overall health of our Medi-Cal members, the goal of CalAIM is really to transform the current system to better coordinate physical, behavioral, oral health, along with public health and social services. Again, the idea is to enable benefits to be more easily accessible to members, and provide services when they need it and where they need it. So a few examples. So for example, we under managed care, we are standardizing managed care enrollment statewide to enhance coordination of care and reduce complexity. So CalAIM will standardize which groups of Medi-Cal will be required to enroll in managed care versus fee-for-service enrollment across all 8 codes, all 8 code groups statewide. So the idea of standardizing managed care benefits statewide is that regardless of where a member resides or which plan they're enrolled in, they really have the same set of benefits delivered through their managed care plan as they would in any county or plan. So we do have a rollout effort here, starting with certain benefits like major organ transplant, and then long-term care services. Okay. Another example is behavioral health. Under behavioral health payment reform, we're moving payments to shift from a cost-based reimbursement to fee-for-service, and we're updating medical necessity criteria for specialty mental health care services, developing standardized screening and transition tool. We're implementing a no wrong door policy to ensure members receive medically necessary treatment regardless of which delivery system they enter, whether they're in managed care, whether they're in fee-for-service, and really trying to be thoughtful about reducing administrative burden for counties, providers, as part of our integration efforts with behavioral healthcare services. So, I've primarily focused on eligibility and benefits aspects of CalAIM. Of course, I also want to emphasize foundational impact of financing and delivery system reforms. We are, again, moving towards value-based care and population health. And, we understand that a lot of this effort requires, hard work and commitment of many of our partners, including our plan partners joining me on the panel today. If we can move to the next slide. I do want to just make sure that this slide is here and that you all can see, because I talked about community supports. And these are, again, the optional list of community support services that are available for plans to choose and for members to use. And again, this will be going live as of January 1st, 2022. And the whole notion is for us to build capacity over the next few years so that we really can provide, make sure that the system as a whole has the capacity to provide these services. But, we recognize that communities are different, capacity is different. So we really want to build a phase-in approach and allow that flexibility. So with that provides my overview. I hope I didn't go way over on time, but I will turn it back over to Beau.
All right, thank you, Susan. No, I think you were perfect on time. So one thing I would call out, and I mentioned this kind of at the beginning, that we weren't really going to stick to the acronyms and going through those, and it's really hard to bucket it in three. I would just point out that looking through some of those slides, I saw at least 6 additional acronyms that are critical to CalAIM implementation, and there were probably 10 terms baked into there, which we typically turn into acronyms. So I think just reinforces kind of the earlier comments that CalAIM is not just about 3 acronyms. There's a lot of power acronyms. So I think that was very helpful, Susan, in setting the stage. We do want to spend the rest of our time talking a little bit about what does this mean for health plans, and what does this mean at the community level for providers and community-based organizations is kind of where we want to focus the rest of the conversation. And so I think starting with the health plan side, Martha, I know you and I and probably several other people on this call are, like I said, wrapped up in this all day long, and it's a pretty massive effort, and things are moving extremely quickly at this point, and sometimes changing on a daily basis. But can you give us a sense of what does all this change really mean for the health plans, and as health plans, for those of us who are on the call that aren't as deep into it as you and I are, what does this look like in terms of preparing and getting ready to implement this?
Sure. Thanks, Beau. So, first of all, I just got to say, it's an honor to be able to even have this discussion with, people as passionate about this as I am, as we are. And I mean, just recognizing everything that Susan just walked us through, we are very excited about the goals envisioned by CalAIM, because really the cumulative effects of each of those components that Susan spoke about will drive significant value to the members that we serve and the communities that we operate in. However, it is taking a considerable amount of time, and It is ambitious, and it is also coming at us at a time when the impacts of COVID and all sorts of other issues are real issues that we as health plans, the state, our county partners, our healthcare providers, the community at large is very much focused on. And so, keep in mind that a lot of this is happening when systems are highly strained because of those dynamics. With that said, I will say, though, that the implementation has required an unprecedented level of energy, cross-sector collaboration, regular and close communication, and even deeper levels of partnership between all the stakeholders that I just talked about. And so already, right, the promise of CalAIM is being delivered even as we are looking at the implementation of it itself. And so, this is really a very unique opportunity to address social determinants of health and help really advance health equity. So, we're very, very excited. And, as you think about how this has been impacting the health plans in particular, first and foremost, I got to say, DHCS and Manat and a number of the other consulting firms that they have engaged have done a phenomenal job of trying to stay out ahead of the design process in partnership with health plans, with the county voice at the table. And that is critically important because we're dealing with some very complicated issues, and we all have different perspectives. And so I think, the technical advisory groups and the stakeholder advisory groups that DHCS has stood up are quite demanding and require extensive attention and commitment from the plans and others, I must say it's time very, very well spent. We do feel like we're being listened to. There's very good, strong collaboration and discussion. And it's happening at a very granular level of detail, which is really what we need to do this right out the end. Understand that it's going to take time, right? I think the other part of all of this is that as we've been informing all of this, it's multifactorial, multidimensional, right? Just to kind of give you a sense of the things that we've been focusing on is, eligibility criteria for the populations of focus. What does that look like? What might process and outcome measurement look like? What about reporting expectations, member communications, capturing data, building capacity? The list goes on and on and on. So it's a very significant lift, an exciting one nonetheless. At the same time, the plans have been very immersed in extensive engagement at a local level, right? When you think about just the counties, right, all the counties have different levels of capability, different levels of infrastructure, and want to play a different role in the CalAIM process. So, the Department of Public Health in one county, as an example, may be different than the Department of Public Health in another county, mental health, health services, the housing systems. And so engagement with the county agencies is very dynamic. It's very important and something that we've been highly immersed in, as have discussions with tribal centers, FQHC, provider organizations, community-based organizations, and the list goes on and on. So engagement, deep levels of engagement out in the community is, one of the things that's really impacting us today. We also recognize that transformation requires streamlining, and Susan hit on this in her presentation. And so plans recognize that, and we are seeing unprecedented levels of collaboration. I'll give you a couple of very specific examples. In just about every single county, plans are collaborating on service mapping, meaning understanding what is available in each community that we can build on, and identifying the needs that we need to continue to build upon. And this is really mostly focused today on enhanced care management and community supports networks, but we're doing it together. Another example of collaboration is we've launched an enhanced care management and community support certification process that we jointly developed. And the idea is to really minimize duplication for the plans, as well as reduce administrative burden for our provider community. And I will say that the plans, I think, are doing a very nice job of dividing the labor, and the providers really appreciate it because, we're not having to ask them to submit multiple applications to multiple parties and go through multiple processes. Another area that, we are highly focused on is this idea that we really must integrate non-traditional healthcare providers that have varying levels of capabilities, right? Think about invoicing systems, billing systems, documentation platforms, ability to exchange data, care management platforms, workforce skill, right? The providers that we're working with, some of them are highly sophisticated and have an ability to really deliver at optimal levels, or what we would consider optimal levels today. Some require a lot of support. They're doing very good work in the community connecting with individuals, but they may still need to submit, paper billing or use faxes or all kinds of other things. And so what the plans have been doing is trying to figure out how to support that wide degree of variability in capabilities so that we don't lose the ability to leverage those resources that have been in the community for decades doing the work that we need them to do. As we think about that, we've really had to evolve our infrastructure. And, more specifically, to really very effectively monitor and oversight our enhanced care management and community supports network. We are going at it with the understanding that this is going to be a very intentional journey. And here's what I mean by that. At the end of the day, plans will be held accountable for performance, bridging disparities, addressing health equity, delivering good outcomes. But as I just shared with you, the organizations that we're leading on to help us achieve those goals have different capabilities, right? And so we are very mindful of that. And so we're building our monitoring and oversight systems with an eye towards ongoing improvement. So features of that include training as a foundational component of our program design to just make sure that we're driving towards the best possible outcomes as time goes on. Being tight on process, making sure that we have streamlined processes and baselines that we can build on, over time improving. And ultimately, at the end of the day, as the journey goes on, it's demanding the results as a condition of participation, right? But we know we have to do our part to support that evolution. And so there's a lot of focus going into that right now. Cross-sector collaboration is also very critical, right? So if we're going to really transform delivery system, we got to break down silos that have existed and have been built over decades of policy and other changes. And so some of the things that we've been discussing is interagency partnerships, as an example, to really effectively break down those silos. And that might be everything from how do we handle the care of individuals that are in the justice involved, coming out into the community, needing to integrate? How do we get connected with them early on? How do we support their transition into the community and set them up for success? How do we make sure that the behavioral health, substance use disorder, serious mental illness, mild and moderate behavioral health needs are all integrated and met? And how are they integrated into the physical health? And so all of that requires data exchange. All of that requires communication. All of that requires processes that are tight. And so there's a lot of work that is going on to help advance that part of the program development and design. We're not close to done yet, but that's a key area that the plans are very focused on and understand is an acute need to really deliver on the promise. Data sharing agreements, just a minor detail, but an important one, right? If we don't have the right kind of data sharing agreements and related infrastructure, again, it's going to be very difficult for us to deliver on the promise of CalAIM. And so those are things that we're also very much focused on. And then, just equally important is just the work we're doing in community-based organizations. They are absolutely critical to supporting the needs of the members that we serve. And so bringing them into our ecosystem, understanding that historically they don't speak the power acronyms that we have. They don't speak, managed care ease, right? And so there's a lot of work that's going on to really just make sure we're doing the right work to integrate them. And then, one of our favorite topics, because it's top of mind for many of us, is contracting. What are we doing on the contracting side, right? So we're developing contracting strategies to essentially drive performance, recognizing that we are not going to be perfect out of the gate, right? And I'll give you a sense of what's happening. We began shaping our approach to all of this in earnest really early this calendar year. And we're building it very, very quickly. Keep in mind that the plans have to make sure that we don't shape our strategy before policy requirements, guidance, rates, and things like that are set. And so what has happened is that the Department of Healthcare Services has done a nice job of releasing information as decisions have been made. And so they started releasing some information in July and in August. But really, final guidance and documents were just started to get released in September. Final rates on enhanced care management, as an example, were just released in September. And so now we're really very quickly pivoting to translate the requirements and the guidance into our contracting strategy so we can now work downstream to develop our network and make sure that the downstream providers are fully aligned with what is expected of us. And so, with that said, one thing I would really like to emphasize is that we really recognize that our network development is going to expand over time, right? Where we start in January is not where we will end up by the end of 2023. As Susan and Beau said, this is really about a journey and building capacity. And so we wholly expect that we're going to incrementally expand, evolve our network to meet the needs as the time goes on. And there's a lot more to do, right? A lot more to do. Just to kind of name a few things: onboarding, training, ensuring smooth transitions for people in health homes and whole person care in January. And I can go on and on, but I'm going to stop there and just reiterate the fact that we are very, very pleased that the state's making such a bold investment in whole person care, because really it is key to advancing health equity. And all the plans, I could safely speak for all the colleagues that have been sitting around the table with us, are all in trying to really make this successful. So hopefully that was helpful, and I didn't go over time.
Thank you, Martha. That was extremely helpful. So I'm gonna transition into a slightly different aspect of this, which is focused on what does this really mean at the community level and the provider level. I do see a few questions in the Q&A here, and encourage everyone, if questions pop up, please enter them here. The first two questions I'm going to attempt to address as I talk through my points here. If I don't, please call me out and let me know. One of them that I'll go ahead and address now, though, and Susan, you may want to weigh in on this one as well. The question is, how will this impact Medi-Medi patients? So individuals who are receiving both Medi-Cal and Medicare. And from my perspective, and Susan, again, feel free to add here, but I really see this happening kind of in two waves. So, today we are focused on what goes live January 1st, and two of those core components are both enhanced care management and these community supports. And individuals who are Medi-Medi who are enrolled in a managed care plan will be eligible to receive those services. I will say it makes it very difficult sometimes for us to do full coordination if somebody has their Medicare in fee for service, or it's in in a different delivery system, but they are eligible for these benefits. The bigger change, though, I think for the Medi-Medi population is really going to come a little bit further down the road, in which a couple of years from now, I think it's the end of 2023, the CalMedi Connect program, the duals demonstration program, is actually going to end, and we're going to be working towards better integration between dual special needs plans and the Medi-Cal delivery system to ensure that individuals, even though Medi-Cal and Medicare are two different things, that we're able to better connect those dots and better coordinate services between them. But that's kind of starts at the end of 2023 and comes in through multiple phases for a couple of years after that. So I think that's kind of a long-term goal for the Medi-Medi population.
Right, Beau. I think you summarized that really well. I think what I would add to that is, really trying to, we are working through policy to really, again, this notion of streamlining and making things less complex, especially for our duals members, trying to have that aligned enrollment between our Medi-Cal plans and D-SNP plans, so we can ensure that, in fact, our members can use the same plan for those services. So I think that will go a long way to streamlining and reducing some complexity. But again, that is further out, as you said. And then going back to the ECM component, yes, I didn't really get into the different populations of focus for enhanced care management, but certainly seniors and persons living with disabilities, and including those at risk for institutionalization and those folks who are eligible for long-term care, living in nursing facilities, are all part of the populations of focus that enhanced care management is designed to provide that, again, that care management at the level of intense care management that those folks will need. So I just want to flag that as well.
All right, perfect. So I know there's other questions coming in. I'm gonna work through my part here relatively quickly so we have enough time to dig into some of these other questions. Really the question that Kelly, as she was moderating, was gonna throw out to me was related to starting with, the Health Homes program and the whole person care pilots and the work that's happened over the last few years being kind of the starting point, and how does this continue to change relationships between health plans and community-based providers was kind of the focus point here. I would argue that, Health Homes and whole person care actually wasn't the starting point. I think we've seen this over the course of probably the last 10 years, even, going back to early discussions around the coordinated care initiative and the integration of long-term services and supports, which seem to align with kind of this nationwide trend and really a larger push to better integrate healthcare services with social determinants of health, and really looking at the whole person instead of just looking at the physical health needs or the behavioral health needs, but looking at all those psychosocial needs that really have an impact on somebody's overall health as well. But over the course of the last decade, it feels like this gap between the healthcare delivery system and managed care plans and community-based organizations who are doing some of these things is slowly started to shrink. And again, it started with LTSS and even with CalMedi Connect and health plans doing things like care plan options, which was kind of a precursor to the community supports we're talking about now. And then with Health Homes and whole person care, definitely, like, those were huge steps forwards, I think, in terms of having the delivery system start to change and really focusing more on this intensive level of care coordination that happens at the community level, working with FQHCs, and then starting to partner with other community-based organizations and counties, and really, over the course of the last 5 years in whole person care, working with partners in a completely different way, getting to a point where we're sharing data across systems, and there's all kinds of MOUs and data sharing agreements and contracts in place now with, a variety of community-based organizations that didn't exist prior to some of these things happening. So, and now I think what you see is with CalAIM implementation, this is really the next huge stepping stone. It's this ongoing trend, and it's now another giant leap forward to better integrating services across these multiple delivery systems. I will say that, through, I think, whole person care and Health Homes efforts, I know we've done this, and I know, Martha, your plan has done this as well, but we've all kind of dipped our toe in the water with various SDOH related pilots that now fold into some of the work we're doing with CalAIM, whether it's looking at medical respite or housing navigation programs or food insecurity programs and different things like that. So, we've started to dive into this, and I think from a plan perspective, Martha, I think you called this out as well. Like, we see this as a huge opportunity. I mean, honestly, a lot of the things that we're able to do under CalAIM are things that I think health plans have wanted to do for many, many years, and recognize that, hey, we should be paying for these types of services because they impact the overall health of our members. But there have been limitations based off of, how we get reimbursed and our contracts between the state and what CMS requires from the state. Our hands have been tied a little bit. So, we do see this as a huge opportunity to continue building stronger relationships with local community-based providers. And I think Stephanie threw out the question about, in lieu of services or community supports being opt-in when everybody needs it. And I don't think anybody I know at any of the health plans would say, yeah, we're not going to do this because we don't think members need these services. I don't think that's the approach here. I think, long-term, and I can only speak for Anthem, but long-term, our intent is that a few years down the line, we are able to provide all 14 of these services in every one of our communities. But the reality is that the infrastructure is not there today to do that on day one. And I believe that's, from the state's perspective too, that's why we're viewing this as more of an opt-in instead of this is mandated starting at the beginning. It gives us an opportunity to engage with local community providers and really build out this robust infrastructure for the services to be delivered. And some of those things, honestly, are a little bit easier to stand up than others. I mean, if you look at some of those services like sobering center services or the recuperative care medical respite services, if there is nobody in the community providing that service today, that's not easy to stand up because we have to engage at the local level, find out who's willing to take that on, figure out, what capacity and what funding is going to be needed to stand that up. It's a long process to open up because those are facility-based services, and it takes a while to stand that up. So I think that's the ultimate goal, is really for us to get to providing these services across all of the counties, but it's going to take some time to get there. And then, in terms of the other question here from Josh around, impacts of CalAIM on health equity, I think we're going to see the impact almost immediately, but it's going to be something that we see more and more as time goes on. And I say that because, our experience with health homes, whole person care, and some of the pilots we've done that now feed into these community support programs, we've been doing them for a couple of years and we have seen the impact. We see the impact on our members. We've built those programs to make sure that, we're tailored to populations who need them most. And it's all about, the messaging and the outreach and how do you engage those individuals and make sure that they're really getting what they need. And we've started building that in and I think seeing some early impacts. So I don't think it's a matter of January 1, it starts and we don't see anything. I think we'll start to see some impact pretty quickly, but then over time, it's just going to keep growing. And, 5 years from now, 10 years from now, is really where we're going to look back and say, man, this really made a huge difference. So, the other thing, from the provider perspective, as I mentioned, from the health plans, we're continuing to grow and build these stronger partnerships. From a provider or a CBO perspective. Really, I would hope that providers and CBOs feel that this is also a great opportunity for them. I mean, the reality is that, the delivery system is changing. CalAIM was not the starting point, but it is a huge stepping stone. And I doubt that it's the last stepping stone in the transformation of the delivery system. But we know that, connecting all these dots between these different programs and services is really the right direction to head. And it's the way to best address the needs of the Medi-Cal population. So there's a lot of opportunity, I think, for community-based organizations and providers to get engaged, start working with the health plans, figure out, how does their organization fit into this, and really think through what does their organization need to do to change their service model. I think that's kind of a big thing that we see throughout the state is while Martha, I think you talked about how we have to do things very differently as we're going into CalAIM. From a service provider level, you have to kind of rethink your delivery model as well, because what the community-based organization is doing today may not work under CalAIM, and you may need to make adjustments. There's definitely going to be additional reporting, and the billing processes are going to be different and everything else. But however, I think one thing we haven't touched on too much is there's a lot of support to make that change happen and to build strong partnerships. There are incentive dollars baked into CalAIM, which will be flowing through the health plans in order to allow us to invest in community-based organizations and providers and build out capacity, implement system changes, do whatever they need to do to make sure that they're able to provide these services. There's other funding through the state, through PATH and the Home and Community-Based Spending Plan, which has certain components that will support CalAIM as well. And on top of that, I think, from a health plan perspective, we are providing quite a bit of support to our community providers to help get them ready to provide these services. This isn't a matter of, hey, here's this new requirement and we're looking for providers, and tell us, call us and then we'll sign a contract and it's done. I mean, this is a very robust and intense process that we go through at the community level to really engage deeply, figure out what's available, what the gaps are, what we need to do to plug in those gaps, and what we need to do as a health plan to help community-based organizations get to the point where they can deliver these services going forward. So I will stop there. We've got a few minutes left, and I see quite a few questions. I think we took the first three. There was a question about reimbursement rates for ECM. So I will say that we are very close. I think most of the health plans are very close on this. We did within, I think it was just a week ago, maybe a little bit longer, we did get some additional information from DHCS, from the state, on how ECM is going to impact our rates as a health plan, which is something that, was pending for quite a while and holding us up. And I think at the plan level, we're still sifting through that and trying to figure out how does that translate into what we're actually going to be able to pay the providers for ECM. I know that's been a big sore point for in a lot of discussions. It's hard to commit to doing something when you don't know what the rate's going to be, but I think we're very close to that. Do you have anything you wanted to add there, Martha?
Yeah, no, I was going to chime in because I know I shared some of that in my comments, and I think it's really just important to recognize that that translation, Beau, that you speak about is an important part of the process, right? And so my guess is that over the course of the next several months, plans are going to be in a position to really engage in earnest on that with the providers, but it's going to take some time, right? And I don't mean years. I mean, we're going to have to, kind of nail this down and get feedback and incorporate it into our strategy. But the good news is that especially the whole person care lead entities did a phenomenal job of educating the plans around their own experiences in their own program. And we did share a lot of that with DHCS. In fact, DHCS did make changes to the initial set of rates as a result of a lot of that feedback. And so I think, if you're a provider out there, just kind of bear with us, allow us to do the translation, and you'll start hearing a lot more from plans on that here shortly, I believe.
Yep. All right, thank you. So I think we got time to tackle one more. The other one I see raising to the top of the queue is around how does CalAIM inform the shift of Medi-Cal pharmacy from managed care plans to Magellan? Susan, I'll let you address this. I think the pharmacy carve out was actually part of CalAIM initially, and then the timelines were off, and then they came back together. I think from my perspective, one thing is that's critical with the pharmacy carve out is that we are still working on data exchange with Magellan at the plan level, which is critical because, while we won't be responsible for the pharmacy benefit, having that data built into our algorithms to help identify the needs for ECM and some of these other services is really a critical point.
Right. I would just add that is obviously can't take a whole person care approach if you don't know what medication folks are on and, have that important data component. And so, there is that systems being developed to ensure that there is that data exchange and that data information from Magellan to the plans, and make sure that you can still get that information to provide that care management services. So so even though the plans themselves are not directly responsible for providing that benefit and it is carved out, there is still a expectation that plans will be taking that data and using that to manage the whole person care services.
Yep.
Somehow.
Okay.
So there's a couple, if you don't mind. There's just two quick questions I think we can hit on very, very, very quickly.
Mm-hmm.
One is there's a couple of inquiries around data exchange and how we're leveraging, broader efforts. What I would encourage you all to do is informed discussions that are happening at the county level, reach out to health plans and just make sure that you're starting to build connections there. The idea is to leverage broader efforts so that we're not duplicating anything. Absolutely. We have had some discussions about how we leverage housing data, correctional facility data, and the like. It's still early on in the process, so you have an opportunity to really just inform the design of all of that, and we would love to hear from you. The other set of questions is really around availability of services that may be out there and how providers can really connect. Plans would love to hear from providers that have any of the capabilities related to any of the community supports we just talked about or enhanced care management. There are certification applications that were sent out to a variety of different stakeholders. I would encourage you to reach out to your plan partners, and maybe we can give our contact information to the state of reform folks to distribute more broadly. But certification applications are being accepted for a variety of services. And as I said, I think Beau reiterated, the idea is that the network that we start with in January is not the network we're going to finish with. So I think there's still plenty of time to make sure that we're taking advantage of the services and capabilities that you all have to offer.
And I can just add there, Beau, you touched on yet another acronym, PATH, which stands for Providing Access and Transforming Health, which is a set of funds that DHCS is using to help build capacity and really helping build that technical capacity with community-based organizations. So we are in the process of getting approval from the Centers for Medicare and Medicaid Services in terms of all our initiatives for that specifically. And then once that is, we have a green light, we are going to be rolling that out. But the concept is essentially, as Martha mentioned, think about the gaps potentially of CBOs. There are many organizations that have never contracted with a managed care plan. So how do you think about, maybe contract templates or other kinds of tools that could really make that simplified and really help CBOs kind of hit the ground running. So we're thinking about how to leverage those dollars to really help build capacity. So I wanted to make sure we talk about that. Mm-hmm.
Thank you, Susan. All right, so we are a few minutes over, so we'll end there. I do want to thank Susan and Martha for joining me on this panel, and DJ and Kariana and the State of Reform team, and also Patrick, who's kept the technology going and made sure I didn't blow anything up by pressing wrong buttons. So appreciate the engagement and all the questions, and I hope everybody enjoys the rest of the conference.